outpatient clinic and bedside teaching, an art and a science. And over to Dr. Grover.
This is not what I connected.
We've asked him to keep it on for about seconds.
It's a wonderful initiative that OFAC and AIOS planned this joint program, because OFAC has been doing such a wonderful work. It's a joy to be a part of that initiative, and it's good that we in India are being exposed to the work that they're doing so that we can take more benefit of the initiatives that they are taking. It's worth visiting their website and the work that has been done so far. I think it has already been introduced to this audience. Thank you, Meenakshi, for making me a part of this program. Thank you all for being here. Great to have such a wonderful audience with people who are such great devotees of ophthalmic education, I would say, more than anything else. So, outpatient clinic and bedside teaching. So, in reality, we're talking about clinical teaching, which we all imbibed as an art and imparted as teachers as an art, but the science behind it is also immense. In fact, what happened was, when I was in Guru Nanak Eye Center, I started teaching in the faculty. When I was completing 8 years and leaving for Gangaram, that was the time when I attended my first workshop on ophthalmic education after 8 years and got an idea that there was a science. So you imbibe so many things by your day-to-day experiences and your impulses, and then when it is put in an organized way, in a thought-out way, it makes so much more sense. So we need to know it both as an art and a science. So as Osler said, to study the phenomenon of disease without books is to sail an uncharted sea, but to study books without patients is not to go to sea at all. So clinical teaching is really the core if we are to train clinicians and surgeons. So bedside teaching or clinical teaching is an integral part for developing what is our objective of giving evidence-based medicine to our patients. So we are going to discuss why should we teach at the bedside or in the clinic, what are the positives, and let's look at the negatives also. Let's look at the constraints. How do we carry out clinical teaching? What is the methodology that we can follow for it to be more effective? What we should do and what we should not do in clinical teaching, how to assess the learners, and how to give them feedback for us to be more effective in clinical teaching. So teaching on the bedside is important because it's the most effective modality, and clinical skills obviously can only be transferred by clinical teaching. No theoretical training can do anything to impart clinical skills. And then, most importantly, the professionalism and role modeling of skills and attitudes are learnt in clinical settings only, and communication skills are also seen and developed during those sessions. So it is the right kind of context, the kind of context that you need to have, because that is the real life scenario that they're going to have. They're going to see patients. So that is what is important. And he's using all his senses at that time when he has to do observation, palpation, and think about it, use all his senses in order to have a clinical decision making. And therefore, it also creates a much better recall in him because he's using all his senses, and it also increases his motivation because he's in a real setting. He's seeing the benefit, so he's much more involved. So that is the important, he/she. So what is achieved is that when they see an experienced clinician handle a patient, they know how to approach an individual or a human being or a patient as a human being, take him holistically and not just the symptoms or the signs. It also allows the clinician to observe the student's skills, his method of examination, and correct him too. So if we were to summarize it, it integrates clinical, communication, ethical, problem solving, and decision making skills. So all those skills are only coming into play when we do a clinical teaching. Now, the shortcomings are that it's fairly time consuming. It's much easier to download from AI, as Prashant said. He'll get a good, put in all the data and get a good account of differential diagnosis. But clinical teaching would take much more time. And there is also the question of privacy of patient and troubling him, or 5 people palpating him or examining him, and so on and so forth. So therefore, there are constraints. One is that clinicians are busy people who have a lot of work to do, clinicians, surgeons, so there are time constraints to it. And sometimes preceptor thinks that he's going to achieve a lot more, or he's inexperienced enough not to know what to do, what not to do. He may also have false concerns about patient being inconvenienced, or at least exaggerated concerns, let's say. And this has been touched upon by Prashant again, that learners these days think they have a lot of material available from elsewhere, digitally elsewhere, so they get often distracted. They look up things then rather than listening at that moment. So to promote teaching in the clinic, it is important to make sure that patient is comfortable, because that is an integral part. Unless that happens, you would probably not be effective in teaching. Have a professional approach to make patients' comfort better, make him aware that this is being done and that these are students and that this is what they're going to do. Not do anything which will be possibly be too troublesome to him, but at the same time, do not have exaggerated concerns about patient's comfort or talking in front of him. But how should we go about this exercise for it to be most productive? We should plan it well. Exactly think about what is the objective that is planned for that particular session. Allocate time for it. If you don't allocate time for it, you would probably never get down to it. We should think about how we are going to go about it, structure it well, and make sure what you are doing is a part of what we want to impart. It is a part of the curriculum. And we must at the same time assess, and as we'll say later, give a feedback which is effective, which tells the person how to improve with what we have assessed. So make a focus plan of what you want to achieve for a particular encounter, and put a greater emphasis on that part. Say if you think that you're going to emphasize more on history taking that day, spend more time on that to make sure that that is what is emphasized on that day, or a physical examination or patient counseling or breaking bad news, because you can't do everything in one such structured clinical program by a clinician. So we'll go through the components of clinical teaching. Art of history taking is very important, and this is what all clinicians know, that you are down to a differential diagnosis of maybe 3-4 small entities after you've seen the patient, heard him, taken his history, known his age, sex, and the concerns, how they are expressed. All those things, inputs are important, and you're left with very few things to focus on in your examination often. And then the skills of clinical examination. This obviously is so important. Proper technique of examination, being able to pick up the signs. They need to be shown those signs so that they can are able to pick them up, because as we know, you only see what you know. So interpret the signs to make a differential diagnosis, analyze them well to think up a sequence of events, and make a plan of action. These are the usual things we say, but it is important to build that thought process in them. And then learner can be observed in the process of clinical examination and corrected, as we said, which is only possible in a clinical setting. And this cannot be overemphasized, even though it is being repeated. Communication, courtesy is what needs to be learned, and this affective domain, compassion, empathy, this can only come if they have a real life experience of this being done, and that's where a role model comes in. So a role model not just needs to have clinical knowledge, clinical skills, clinical art of history taking, he needs to have personal qualities and the teaching skills. He should know, he should be able to impart them, and he should be a role model in the real sense. Okay, so, but what we do need to avoid is being critical of the student, critical of to be done in front of patient, because that gives a bad taste to the student and to the patient as well. So that negative message must be avoided, and things you can give that kind of a feedback if required separately. So a negative feedback, arguments, angry tone, and criticism must be avoided in clinical teaching. Now, different models have been spoken about. For the younger of the early learners, the model of sitting in, where the students are with the preceptor and they observe what is being done, or then they can break out into, with the patient, come back with the feedback, report back model, that they go to different parts with the patient and then come back, or apprenticeship or parallel consultation model, where they are doing a parallel consultation but taking a feedback at the end where required from the preceptor. So the last two parts are feedback and assessment. So one is that at the end of the session, you can ask the learner to look back at what happened, what the encounter was like, and what he felt were the positives and the negatives. And make a direct observation, but try and make the feedback in a few focused areas. Don't be too general. If you give a very general feedback, if you say you are bad or you're not good or you made a mess of it, it doesn't help. So if you're more specific on what went well, what needs improvement, and be constructive, then you are able to get a much better output. So there are a number of methods for formative assessment, which you do direct observation. O6 is one useful way of doing it, which is relatively objective. Case-based discussions, formative OSCE, objectively structured clinical examination, and feedback from different sources about a person's clinical behavior, from nurses, from the other staff involved. So O6 was an objective tool given to assess patient care skills, medical knowledge, as well as the interpersonal skills. And this is how it works. You have the interview skill, examination, interpersonal skills, and case presentation part of it, with different parameters assessed in a scale. And we in the national curriculum tried to simplify it for Indian conditions, make it simpler, use lesser number of parameters so that it could be used more often in the day-to-day feedback. And we had put this down in the Medical Council of India recommendation as an internal committee for MCI to adopt it. But unfortunately, that board of governors got dismissed soon after, so it never became a part of the curriculum. So to conclude, I think this needs no emphasis at all, that clinical teaching forms the backbone of all clinical learning, and we must all go through that whole gamut of it. And there are no shortcuts to it. No AI will tell you, or no other source of information will tell you. You will not get the wisdom by any shortcuts of getting the information. So effective understanding of the clinical teaching as a modality and using it effectively is critical to making it a useful tool. Thank you all.
Thank you, Dr. Grover. I invite Dr. Parikshit to speak about setting up a wet lab. And while he's getting ready, just a couple of announcements. Those who registered for attending the course online will be given a certificate. It will be handed to you at the end of today's program. And those who have just joined us without registration, perfectly fine. We would also be getting a certificate to be given at the end of today's program. Over to you.
Thank you, Dr. Meenakshi. Good afternoon. I'm speaking to a hall full of ophthalmic educators and I think titans in the field. So this is very basic, something that I'm talking. But thanks, Dr. Meenakshi, for including me in this. One is how to set up a wet lab for residency training. Well, why do we need a wet lab? Like they say in the army, those who sweat more in peace bleed less in war. If you have a wet lab, if you have done your training well, chances of something going wrong are less. And today this has become even more because today residents do not get the opportunity to perform enough number of cataract surgeries to really hone their skills. It's a study we had done about 15 years ago in Pune, in which we had found that the median cataract surgeries that were done in the 12 institutions in and around the city was less than 10 for a 3-year residency. And phacoemulsification or non-cataract surgery was, it was just not covered in many training programs. This is a pan-India study that was done by the ARC AIOS about a decade ago. And here also, if we see only in manual small incision cataract surgery, and there is a wide range, and if you will look at the mean, for the manual SICS, the median is somewhere around 50. There are huge amount of outliers, and in most of them, the median would be nearing to 0. In fact, half of the residents in Indian residency programs did only one phacoemulsification during their residency. And in most of them, they did not get to do any glaucoma surgery, no trabeculectomy, no strabismus surgery. We can perhaps say, okay, vitrectomy, retinal detachment surgery, refractive surgery, LASIK and all perhaps can be kept for fellowship. A lot of oculoplasty, ocular oncology can be kept for fellowships. But even other than a chalazion and a pterygium and some amount of cataract, it was not there. In fact, when this was compared with doctors who were trained in the last century, the senior lot of doctors like Dr. Grover here, they had perhaps done more surgeries during their residency and immediately after that compared to the newer crop. And if we look at the publications that have come during COVID times, where for almost a year, for 2 years, ophthalmology residents have been put only to COVID duty. Of course, when there is a war, it's not just the soldiers, all the supporting members, the cooks, the cleaners, everyone has to fight. So all of them, yes, did a COVID duty, but then they have set out to become ophthalmologists. What about them? And when will they learn it? This is where wet labs come in. This is a recent publication that had shown that residents who had spent more time in wet labs had lesser complications, had better outcomes after cataract surgery in terms of posterior capsular rents, vitreous loss, aphakia, all of that was less. The visual acuity improved. But most importantly, wet labs gave trainees a space to learn in a risk-free environment. And if there was a particular step of surgery that they found challenging, they could do that step again and again till they honed it. And that also helped enhance their psychomotor skills, hand-eye coordination, which is very, very needed for microsurgery and ambidextrosity. I remember 30 years ago when I learned cataract, we learned it first using the cryo and then with ICC. And if a vitreous would come, well, you could always cut the vitreous and suture it and be done with it. And as long as you didn't really mess things up, your supervisors or your seniors would be quite happy with you. Today, all of you in the room, all of you have residents, you have fellows, and everybody is more anxious or more scared of what their trainees would do because the patients and their relatives and their caregivers have changed hugely in last 30 years. Earlier, if the outcome was not that good, if a patient could see 660 or 636, patients would still be happy, would be grateful. If they would not be grateful, they would perhaps just be grumpy, but it would end at that. Today, patients can sue you, patients can file complaint against you, they can go to your medical superintendent, your dean, raise a ruckus, and cause a headache, not just for the trainee, the resident, but also for everybody up on the hierarchy. And so this is that if somebody is not very good at doing things or is slow, well, he'll learn later, or, let things be. The second thing that has happened is our government, in its enthusiasm to have more and more doctors, earlier we would have about 150 medical colleges in the country. Today there are about 350 medical colleges. And this government is planning that by the end of the decade, there will be 700 medical colleges. In Maharashtra, almost now every district hospital has its own residency training program. And many a times that training program will only have one teacher who will do the training, whatever that is. So because of that, as there is less number of people to supervise, more number of trainees who want to learn, obviously what each trainee gets is getting lesser and lesser. So how will they then become good surgeons? This is where wet labs come in. Because teaching is not equivalent to learning, and as Dr. Garg said, with AI and everything, there is so much of extra knowledge. So what our youngsters have is perhaps knowledge excess, but what they have really is a skill deficit. And this skill is something that can be learned only if they do it themselves. And earlier we were lucky or unlucky enough to have bosses or teachers who would literally, kick us on the shin and at other places so that we learnt it. Now it's not possible to do that with the youngsters. And the residency trainers themselves have so many other demands on their time that they just cannot devote it fully to do it just see that the youngster learns. So this is where wet labs, which are stress-free, risk-free, not just for the trainee, but also for the trainer, where various methods and techniques can be tried. They can be tried repeatedly to improve psychomotor skills, hand-eye coordination, stereoscopic visions, to manage possible complications, and most importantly, to improve self-awareness in the residents, in the trainees, so that we give better outcome to our patients. So this is a publication, again, Dr. Lalit Verma's publication with Deepak, as to how to set up a wet lab, and I'm sure all of you are aware of this. It's there in the institutes, and the the boxes that need to be ticked for it. So the room, the curriculum to build hand-eye coordination, the fixing devices, procuring eyes, preparing eyes. Nowadays we have simulators, as Dr. Akshay will tell about the Help Me See simulator that we has. There are a lot of surgical video viewing sessions, so you can actually see it again and again, and therefore improve it. But the two most important things, I think, that are there is the 9th and the 10th. One is the responsibility and the ownership. If there is a wet lab, somebody has to take a responsibility of that, own that wet lab, and see to it that the trainees definitely do it. See it as something that is going to really help them in the long run. Even if they don't perceive it in that way, well, at least they are still made to undergo it. And some amount of a financial commitment is given to the wet lab. Otherwise, generally, most wet labs are the old microscopes, the phaco machines which don't work well, and instruments which can no more be used in a proper operation theater are now shifted to the wet lab for the residents to use. And then they learn on things which have never been very good, and then, of course, we blame them for not learning it very well. So we've had pigs and goat's eyes to teach phacoemulsifications. I remember we used to teach our residents using the cigarette carton transparent covers or boiled tomato or potato pills to do CCC, the complete circular capsular excess, because that was one of the most difficult steps in cataract surgery. And it's not just for cataract. Bacon has been used in USA for strabismus surgery, or for trabeculectomies, they have used half-cut golden apples, or in Japan, they have used quail eggs for teaching vitrectomy. So there are so many, avenues that are easily available, which are not very expensive, that can be used to teach the youngsters. So these are all wet lab eye substitutes that are there. So we can use, banana peels, we can use animal eyes. And things like suturing can be very easily taught. Even many of the diagnostic tests like applanation tonometry, gonioscopy, which are difficult, which are uncomfortable for the patient and therefore cannot be done again and again, can also be done in a wet lab. So we have these eyeball fixating devices. And here, of course, procuring the eyes is difficult, but most institutes nowadays have eye banks. And even in the best of eye banks, their use of eyes is never more than about 50 to 60%. Nowadays, of course, most eye banks take only the corneal rim. They don't harvest the entire eye, but well, they can do that. And of course, there are many artificial eyes also that are available. The cost is not much. And this is something which the AIOS also has been doing for the past 7-8 years. The SSTC, the TSTC, they are all wet labs that have been constructed, but they are all temporary wet labs. They are for residents, for youngsters, or people who have gone on a maternity leave or have taken a break from their careers and are coming back. It's good for a temporary hand-holding, but there has to be a permanent facility where people can again go back to. And of course, there is a whole lot on simulators, which we'll hear later. But then simulators are excellent, but then they are expensive. They are not that readily available. So wet labs are a bit wet and, well, not that clean, but they can be an excellent alternative for these simulators. And they are something that can be tried in each and every medical colleges, NGO hospitals, wherever youngsters are being trained. This is residents with poor training gets fewer and fewer cataracts to operate upon, get less opportunity post-residency for fellowships and senior residency and consultancy position. And many of them remain locked in a vicious circle of their skill deficit because they didn't learn well, or I would say they couldn't learn well during their residency. They find it more and more difficult to learn better when they pass out. And many of them end up being just medical ophthalmologists or going on to subspecialties which do not involve a lot of surgery. So we need wet labs because this is something that is very easily available. It's not very high tech, therefore it's not very glamorous, but it can be a bridge to help address this skill deficit which is becoming more and more common in our newer ophthalmology generation. Thank you.
Thank you. Thank you, Dr. Parikshit. Potato, tomato, banana. That's what I heard. I'm sorry, just kidding. But we move on to a very, very relevant question which he has brought up, which is how about simulation? Where is simulation-based training fit into this scheme of things? And Dr. Helena, I invite you next, is a pioneer in simulation-based training. And she's going to be comparing conventional method of getting a resident ready, a trainee ready, through wet labs and actual surgery versus putting them first through a simulator. And then we'd love to hear comments from the Help Me See, what do you call it, champion, Dr. Akshay.
Ophthalmology Foundation and the All India Society, Ophthalmological Society, for the opportunity to have this space where we can speak and explore and think about health professions education. Thank you so much, Professor Meena, for having me involved so actively. Well, I think this is not the right one. This is for after the, okay. Just a little bit of a spoiler for the afternoon. Okay, so this is the correct one. Yeah, please. Yeah. So, so the goal in objectives, in this builds on the marvelous presentations of the exceptional presenters before, is to appraise the importance of the threefold structure. So we will be focusing on the structure of a session of simulation-based education. So we have seen some techniques before to give feedback, and also the importance of building a wet lab. And now we will focus a little bit, zoom of the session in the structure of that session. So explain the rationale and the process of pre-brief, create outcomes-based learning by simulation, and explain the rationale and process of debrief. So a primary aim of healthcare simulation is to keep patient safety, and by that to engage learners in applying knowledge to activities, rehearsing clinical skills and behaviors, and this builds on the previous presentation on the importance of building a structured wet lab, and ultimately to learn for the learners themselves, to learn, demonstrate, and maintain new knowledge and skills and attitudes, because this is not about just, when we speak about simulation-based education applied to surgery in ophthalmology, it's not about just only the procedural skills, but also the way that we behave before the surgery, the pre-consultation, the surgery itself, how we relate, not only how we proceed as surgeons, but also how we relate with the team in the OR, and afterwards, after the surgery done, the post-op care with the patient. And for all that, it should be included in a thoughtful and holistic wet lab program. So what we aim is to improve, to keep patient safety, I would say, because it's not about improvement, it's about maintaining patient safety, and also build competent healthcare practice. So when we design for simulation-based education, of course, we have the learning activity in mind when we have those sessions available for the residents, fellows, practicing surgeons as well. For new techniques, we keep learning. We are lifelong learners as we practice. But we also must take importance to the pre-brief, the moments that precede the learning activity in itself, and the moments that will follow the learning moment as the debrief. And we will speak a little bit about these three moments of a simulation-based education in a wet lab or simulation environment. When we speak about pre-brief, what we are speaking is about communicating very clearly to the faculty, to our colleagues, but also to the learning community that includes the participants, the learners, residents, fellows, practicing physicians, ophthalmologists, nurses, whomever is there to learn exactly what is expected from them to demonstrate after that session or after the program that can comprise several sessions, to demonstrate afterwards as a result of practicing and having this program. So this should be an introduction that should be fluid in terms, it should be side by side. When we spoke some minutes ago about flipped classroom, we could see the teacher as a facilitator, not so much as the sage on the stage, dominating all the information, all the wisdom, all the knowledge, but someone who is willing to learn as well and has some experience and should lead the group to the outcomes that are predefined at the outset of the session. Then we also aim to create a safe educational environment, and by providing this, by creating this atmosphere with the learning community, with the faculty, with the facilitators, with the experts in content, those who are more expert, for instance, in some surgery, some surgical skill, the facilitators that will be there also to help the learners to attain the outcomes that were predefined, and the learners themselves, so that learners can be appropriately challenged according to their level of ability. And now we are thinking about the needs assessment that we should have conduct and should also, this is an opportunity also for assessing what our particular group would be more interested to develop. So there's a basic assumption when we are speaking in this moment of the session, the simulation-based education session, that we believe that everyone participating in simulation activities is intelligent, capable, cares about doing their best, and surely is there because he or she wants to improve. So the idea is for the faculty to bring the group to the best as they are capable of to attain after the session or the program itself. So prepare the learners for the simulation that will come next, reduce their anxiety, promote psychological safe. So it could be kind of saying that we are ice-breaking the session that will follow. The design ensure constructive alignment, so learning activities should meet the identified needs and align with learning outcomes, should be constructivist in terms that by knowing that, we know that our community of learners will build upon their previous experience, and we had a marvelous presentation lecture about adult learning principles that surely apply here. Write clear learning outcomes, learning objectives with appropriate level of challenge that learners could feel that they will be leaping for the next step in terms of their knowledge and skills, and so they will be, what I mean is that these learning objectives will be attainable by the group, so where they are and leading to the next step. And plan developmental feedback. This is to speak that it's very important. It's good for the learners to go to the simulation wet lab center and practice by themselves, but this doesn't replace a structured program that includes the experts in content, the experts in the particular field of surgery that we are conducting the program on, and also to be there and give immediate and good constructive feedback for the learners. This is just to say that also we should be progressing about these several steps of Maslow's hierarchy of needs in terms of our pre-briefing. So we can be, for instance, when we are working with practicing physicians or those who had, for instance, a leave for an illness or a maternity leave or something like that, and would like to perfect their skills and be more self-confident about the surgery, for instance, they will be probably a little bit higher in this hierarchy. Whereas, for instance, for the residents of the first year who would like to start in their surgery, first steps of cataract surgery, for instance, it will be a little bit different. So this is just to say that we should know very well our audience. Assure confidentiality, so this is not something that would be to be speaking about afterwards with people who would never had any part of this program or were here. And so this is for learners to feel safe and in a protected environment where they can train and they can be, bringing up their best. Orientate learners to the simulation environment. Remember that simulation is a social practice, so this is a group. Usually we don't have only a participant, but several participants and a faculty of facilitators and one, two experts in content united. So for the program director, it's very important to think about this and how it will be important to make the group cohesive. And negotiating a fiction contract. So So having something that the learners, and probably this would be some kind of a hope for this contemporary learning, is that we have this contract with the learners that they will achieve, that we will make them possible to achieve this and that learning outcome at the end. So we will offer them our presence, our skills, a program, material, tools, so that they can reach this step. And don't rush the pre-brief. This is a very important moment, as well as it is the moment that is following, but this is something that will pave a good learning environment for what's next. Assert the basic assumption, as we said. Adopt a position of humility. I think it's for everyone there to feel that everyone has something that will be different from others and will have the responsibility to collaborate and bring up to the table that experience, so that the group, as a group, can evolve in terms of individual development, but also as the group. And this is when we come to the learning activity, that should be structured. It should be based on a problem that was found. We should know our learning community, as I said, so the needs assessment is a very important phase. And also create and establish very clear, smart goals and objectives that will link exactly to what will be measured at the end of the program as the learning outcomes. That should be what the learners should show they are capable, achieved as a result of participating in the program. So this is just to say that learning objectives that connect with the learning outcomes, and learning outcomes will be, if the objectives are communicated as the expectations of the program, the outcomes are exactly the items that will be what we expect the learners to show. And these should be phrased as specific, measurable, attainable, achievable at the end of the program or session, and should be relevant for the participants to apply in practice, and also time-bound in terms of the session or the collection of sessions that compose the whole program. Now the debrief, this is the third part, very important third part of the structure of a simulation-based education session. It is classically described as non-judgmental. It's the moment that after all have had the opportunity to go to the bench microscopes, try out what was expected to be trained, and then come together either in the same room or in a different room, and together speak about the experiences that the group, the individuals have, and also what the faculty has found as well. So should be non-judgmental, should be the heart and soul of simulation-based education, and the participants, the community, should see the facilitator as a co-learner, because the faculty is also learning how to improve their own program by collecting this experience to the next iterations. So the role of the facilitator is very important. It may not be the expert in the surgery itself or the concept or the knowledge that is given the heart of the whole session or the program, but should be responsible and feel that responsibility to make the participants active and responsible for their own learning, and ensure that the group also walks towards what was defined by the session and the faculty in terms of attaining those learning outcomes. These are also very important in terms of making this environment as informal and trustful as possible. As you can see, usually having people sitting around the table, in a round table, so that everyone can see each other and share experiences is usually good. If this is not possible, and for instance, if there's the need to, I mean, this debrief is also coupling the feedback that should be also provided while the learners are trying out during the program itself, during the hands-on experience. So more individually than this whole session group, as you can see here in the diagrams. So there are several models for the brief. If we go into the literature, this is just to say that we aim at it at the end of any debrief is to capturing what was the best part that learners have achieved and what were the aspects that could be considered as areas of improvement. And this can be done also. We can ask for the learners to think a little bit and write what they felt about their experience, write, for instance, carrying a blog or in a logbook or a portfolio, for instance, for a longitudinal program, should be facilitated in terms that this is very interesting to say, but facilitators should be there. Faculty should be present also in these moments to help the learner to bring up and reflect and conclude what is the best that he or she has attained and what could be improved as well. And for instance, also video playing back, and this can also be done in practice simulation programs, as we can see, record that practice and then comment that practice with an expert or a facilitator. So the idea here is to, what have I done well? What have you done well? But most important is to inculcate, to integrate this culture on the participants, to think about what do I think I have done well? What do I think I can do better? And then compare and contrast this opinion with the opinion of the facilitator. So these are several models, how we can phrase in terms of approaching non-judgmentally, with humility as facilitators and faculty, and be together with our learners. And sometimes opinions do not level. The facilitator thinks something that is not exactly what the learner thinks. And this is also some way to phrase our conversation as we see here. I'm hearing two slightly different perspectives on the way the team approached, the team or you approached something. Here is airway management. Well, let's spend some time reflecting on how and why this happened. This is something that shows that our openness from the facilitator, from the faculty, to reflect about this, and also understand from the side of the learner what make the learner think what he or she thinks happened and not exactly what the facilitator thought it was. In summary, simulation-based education experiences should be carefully crafted around these three important stages: pre-brief, learning, and debrief. Pre-briefing should be intentionally designed to create a psychological safe space to maximize learning. Simulation-based activities, expectations, outcomes, learning objectives should be clearly communicated. Debrief is a special feedback moment. It's a process that, while maintaining a safe learning environment, may uncover emergent learning gaps. Thank you so much. This is a collection, this is endorsed by the Ophthalmology Foundation, that were produced by the committee, the subcommittee of simulation-based education. You are most welcome to visit. It's published and it's all about simulation-based education. Thank you.
Thank you. Thank you so much, Dr. Helena, for the in-depth look at simulation. Is it still something new for our country, or really it's not anymore? That's something we're going to be debating for the next few minutes. And also, any other tips that you have for wet lab that has worked for you, cost effective? And anything else to engage? Is clinic teaching as difficult as didactic teaching, as we talked about earlier. These are a few points to discuss before we come to the even tougher topic of communication and professionalism training. So we'll pause for about 5 to 7 minutes, take a quick round of comments, and then we will conclude this session, the didactic portion of the session, with Dr. Krishna Prasad's talk. You have a comment, please?
See, wet lab is a very difficult proposition for medical colleges and institutions, is standard thing. But I have few kind of parallel thoughts. Most of our operation theaters have microscopes, which we use for our patients. And it's not occupied 24 hours. So most of the time, it's actually not being used. So if institutions can actually change their policy, they can actually use the same microscope for wet lab. Because they say we have to buy a microscope, we have to have a room. It's not really necessary. If you can take care of the kind of the asepsis part of it, if there can be some protocols and SOPs for that, we can probably use our own operation theaters, few probably hours kept apart for wet lab. This is one suggestion. And second thing is always a financial problem. The institution cannot spend, cannot have the budget for it, and a lot of red tapeism. Presently, all the residents have receive a lot of, money is quite sufficient in terms of their monthly stipend. And they can always do a crowdfunding. There are institutions where there are 10, 20 PGs. If they can probably put up like a share, like you can have a lot of companies ready to give their second-hand refurbished or microscopes of phaco machines. So even few lakhs by crowdfunding, and it can be transferable. Like this year's PG can use that microscope and can sell the share to the next batch of PGs. So obviously it goes free for them. So something like a jugaad. So that is something that, and simulators, I don't know, this is my personal view, people may differ. What you say in Hindi, dikhane ki dant hai, aur khane ki dant nahi. We basically have to work on wet lab model rather than simulators, which are not really cost intensive. I mean, they're very cost intensive and cannot be kind of an equitable distribution for a huge PG population in India.
You have a question? Yes, please.
Sir, I am running a wet lab program for the last 12-13 years in my institute. We have 3 microscopes. Those that have been condemned, we are using them. Your suggestion is very good. Once the OT is over, we can get the eyes kept in betadine solution for about half an hour or so, remove the epithelium as it got edematous, and the leftover sutures, the leftover visco, the Blorex, the blades, everything is there, and you can do it then and there. Those PGs who are posted in the morning, who has done the OT, and others can have, even the side viewing system is not there, they can have a loop, binocular loops, they can see it in 3-dimensional. The assistant viewing system is 2-dimensional. Even if you have a screen, it's 2-dimensional. But if you have a loop, it's 3-dimensional. That's I did with the loop. I started. Then when I joined my institute as a teaching faculty, then I started a wet lab program, and we are doing this. I think we have a separate wet lab, but your option is also quite feasible, and everything is quite possible. Binocular loops.
So use a loop instead of a side scope, if there is no side scope. A comment from Dr. Akshay, please.
I actually have a different opinion that when you say simulation doesn't work and that it is not cost effective. Did you know last year LVPI trained 88 trainees on the simulator for SICS and now for phaco. And the cost of a trainee getting trained in a cataract surgery on the simulator as per the prescribed simulation training program costs less than a trainee attending the AIOS conference. So cost effectiveness is not something that's and effectiveness, yeah. So we've actually, in LV Prasad, S. Shankar Netralaya and Mahatma Eye Hospital, there was a case control where one set of trainees directly went into wet lab and into live surgery. The other set of trainees operated on simulators, went into live surgeries. The first 20 live surgeries of both groups of trainees were taken, presented to a group of 12 masked surgeons who didn't know which trainee was for which group, used the ICO Oscar to grade the surgeries and also to give a scoring system based on technique, outcome, and errors. There was a 50% lesser number of errors in the group that operated on simulation first and then into live surgery, better visual outcomes at the end of 6 weeks, and lesser surgical time and lesser supervision takeover in the first 20 surgeries. We've not even gone into the financial implication of better vision at the end of 20 surgeries for the patient. So the concept, virtual reality-based simulation especially, is now gone into a level where we are looking at predictive validity, which means looking at the performance of a trainee on the simulator can actually, and grading that performance, can actually help you predict how good the surgeon is going to be in real life. It's reaching the level of pilot predictive validity, because you can actually get a license to fly an aircraft without stepping foot in an aircraft. That's good, how good flight simulators are. Virtual reality simulators in surgery are reaching that level soon. So not only is it no longer not cost effective, but it's also extremely effective from the patient's perspective, because at the end of whatever we do, the heart of it is patient safety. So if we look at, I don't think cost effectiveness, yes, in a country like India where resources are low, cost effectiveness is one aspect, but patient safety, I think, trumps all of that.
I don't think it's either or. They both can happen. So wherever simulation is possible, yes, but wherever it is not, wet labs. And even places which have simulation, they can also do with wet labs. So they are complementary to each other.
I think one of the other aspects that will come over a period of time is to really gain the experience of managing complication. No wet lab will be able to generate that, but simulation will be able to do that. The second thing that we have observed with the simulation training is it almost gives you a feel of you are operating in operating room, because the microscope is there, your hand movements, everything is. I myself did few small incision cataract surgery on simulation, and I realized that I think to a beginner, this is a very powerful tool of giving them the tactile sensation as well as the knowledge about the entire procedure in that environment. The cost may come down over a period of time, primarily because one simulation you can use entire day, almost 6 to 8 trainees per day you can. And this is 1 week of training. That gives them complete experience of any surgical procedure that you want to. Say, yes, it keeps.
Sorry, you finish.
So even if suppose you enter into the tissue and you are reaching the almost premature entry, as soon as you reach that level, it gives you impulse that you are entering. Yeah.
So it is, we had this simulator in DY Patel. It is very useful.
An instructor-led simulation-based training is actually the crux of it. So if there's a dedicated instructor or someone who's monitoring you, what you do, like in the UK, 50 hours on the IC or VR Magic simulator is mandated towards completion of your residency program. But it's unsupervised. 50 hours have to be logged in with you on the simulator. You can actually sit, turn on the simulator, hold your hands on the joypad or have your entry in the logbook and watch about 10 movies on Netflix and come out. You would still be registered because that gets counted as hours logged in. But here, when there's an actual instructor telling you how to do, what to do, giving you feedback, and not only that, you have assessments on the simulator. So that actually helps.
So, yeah, because Dr. Grover and Dr. Helena.
Your opinion requires not a single penny of investment, except for procuring the eyes. Not a single penny. Just 10 rupees, we get an eye for 10 rupees. That's what
Dr. Grover.
One of the ways of...
virtually in every college, every OT we can train.
yeah. So, one of the ways of increasing cost effectiveness is to have it at community centers where a lot of people can come in and do it. So like the AIOC office now has simulator too. So the utilization can be improved by making programs which ensure the maximum utilization of the high initial cost, which is the constraint which Krishna Prasad is talking about.
Very good point. And Dr. Helena.
I was just saying that taking the the trend of the simulators, probably the price will go down in the future. And what is so exciting is that these machines have themselves something that I have been just trying to get the message across in terms of structure, of being present and giving feedback timely and constructively to the person. You start receiving that directly from the program of the machine, of the simulator. So this is exciting in one way, but at the same time a little bit, can be, wow. So we are completely being replaced in this aspect by simulators. Something that I would like to also bring to the table is about the experience of the simulators that are more and more developed, and we can have the sensation of the haptics, right, of having the instruments and closer to the reality. But exactly, I would like to think with you what you think about the simulators and, for instance, the wet labs with the artificial eyes or the animal eyes, and the differences between both of them, knowing that the simulators in time, they will be equipped with the best of the practices in education. So, but what do you think about this complementation of these two, so the wet lab and digital lab, it's about seeing the videos of surgeries, not so much, but the wet lab and the simulators. And probably in the future, simulators will be more widespread, but right now, what do you think about that?
So there is a limitation of wet labs. You can teach them only few procedures. On the simulator, that limitation is not there. We can teach them intraocular lens implantation, that ring segment, and all of those things. So, yeah, so I'm sure that going forward, these simulators, every surgeon will have to go through so that they can upscale their, I don't know when last I did anterior vitrectomy, and if that thought comes immediately, I feel shivered that will I be able to do good job if I end up having, say, extensive zonular dialysis. So I think these things will improve, and our capability of managing complications, things that are rare in surgery, will improve drastically.
Thank you. I invite Dr. Krishna Prasad to give his talk on how to teach professionalism and communication to our trainees. And with your permission, the two young educators, I think we'll take up Dr. Apurva's case and then break for lunch because we're running behind schedule. And Dr. Rolika, you're anyway part of the next session, so we can start with your case. Thank you.
So, thanks Dr. Meenakshi, Ophthalmology Foundation, ARC AIOS for the opportunity. Thanks for allowing me to learn so much from this session. So we teachers should learn one thing, in my opinion, that we have to a great extent become irrelevant in the present context or in the conventional context. Because our students are spoiled for choices. There's a deluge of information out there. I'm not saying it in the negative sense, because the students can opt out for the best teachers globally. My students can probably log on to reels of Dr. Pranesh for the thing that they want and sleep in my class. So there is no need for them to really seek the guru in the way that we want. So obviously, medical knowledge or the kind of procedural skills, because they can have YouTubes, they can see skills, they can learn so much from the experts in the field. So in this context, these 6 competencies, what ACGME tells, the patient care, the medical knowledge, all these things actually can be sought on a parallel ground, but the professionalism and the communication skills is something, you really need to actually work on that. Because with this, whatever kind of student that we have been discussing so far, the present generation Z students, they are, I would say, dumb, socially awkward, non-communicative. They can't pick up the non-verbal clues from the patient or the other person, and they cannot read emotions. So they are almost in themselves. So this is an obstacle for an effective patient care. See, we have a lot of conflicts because they're not repairing a machine. They're repairing. So you don't have to talk to a machine before you repair, or you don't have to ask how good morning to the machine, nor ask the feedback how the machine felt after being repaired. So they're talking to a human being, a fellow human being. So this is something, that big obstacle that we are seeing, because it's about the competencies. Are we developing the competencies to really complete this picture of creating a very professional and eye care provider who can actually help? So what is professionalism? It's a big definition. It's a habitual, so they have to do it every day, and a judicious, okay? The use of communication. So there's a communication in professionalism, knowledge, obviously, the wisdom, the technical skills that they should know, clinical reasoning, obviously they have to connect the dots, and use of emotions. This is very important. They cannot be non-emotive. So you have to actually show emotions, good or bad, in the right context and right content. Values, you need to show your values. That's very important in the personal context. And obviously they need to reflect on their day-to-day behavior and do necessary correction in their daily practice for the benefit of the individual. So this is what is the actual definition says. But to kind of split it down, for a postgraduate who is in training, basically they need to get committed to their professional competence. See, learning to actually do things right, whether it is the skills or the procedures, is actually professionalism. See, if somebody is not doing their duty properly, if they don't know how to do a cataract surgery, how to do a sac syringing, it is actually, they are not professional. They need to. So it's our duty to actually make them learn. It's their duty also to learn. And the honesty with patients. See, there's a complication, there's a posterior capsular damage, and there's a drop, there's epinucleus, or some nucleus pieces have gone down. You have put the eyeball in the sulcus. What will you tell the patient? Are you honest with the patient? Will you say there is a problem, try to get around that? Or will you say everything is fine, you want to sweep the dust under the carpet? So this is also a professional behavior that we need to actually see. And students come late, they don't follow instruction, they don't write documents properly, they don't document, so they don't follow the prescribed SOPs of the hospital. So this commitment to the institutional discipline, because not everybody is self-driven, we need to put this discipline in place and also monitor it. And patient confidentiality. There are a lot of students I have seen, like, referring, this HIV positive patient should be seen last in the OPD. See, they are so, vocal about certain things, trying to give the patients, personal details, and basically maintaining the appropriate relation. This is also very important. The right kind of use of touch or the non-verbal communication with the caretakers as well as the patients. And obviously you have always finite resources, both time, your, basically all these, when a lot of patients are waiting, if you need to see an emergency, will they really, use their judgment and reasoning and their value system to basically see, is there a triage that works in those people? That is something very important. And very importantly, is the present day mistrust is, there's a conflict of interest, will they really take care? So basically, we need to be a role model ourselves as teachers, because there is nothing, you can't really teach them with, textbooks. And basically, we need to define a document, how expected behavior. It should be written down. The SOPs and professionalism should be actually written down. And you can have workshops, and even role playing would actually work. And the proper feedbacks, you need to watch them. OSEX is a very great way of doing that. So basically, there are a lot of cultural differences. See, each person across India have different cultural upbringing, so that can actually also, it's rooted in that. And we actually, very unfortunately, have a lack of role models right there from the early MBBS days of orientation. We don't actually have professionalism in the curriculum rooted in. And there are students who are, the personality types matter. And not everybody is same. So obviously you can't expect that. There are people who actually do not really wish to be very rude, but they appear to be rude because that is their way of speaking or way of behaving. And obviously if you don't monitor, dandam dashagunam bhavet, if you don't have a penalization, if you don't have a monitoring, you can't expect anybody to be. So coming to the next part, this is something very important. Communication is everything in the today's context. In the Indian context, we need to really apply it to our type of patients, our kind of institutions where a postgraduate sees a lot of patients. There's a huge amount of outpatient that needs to be seen, a lot of OTs to be done. So then this communication takes a setback. we did not have a curriculum as such all these years. Now it has started in the present day CBME curriculum, but we didn't really have a curriculum for communication. And obviously it is from MBBS. The students are never taking history, they're not presenting cases enough. In internship, they just write, only documentation. They're not actually interacting much with patients. So this could be the reason why they are poor communicators, and that's why there's so much problem around all this. I'll just show you a small video. Like this could be...
oh shit. Drop हो गया अपेक्षा.
This is a OT situation.
Drop हो गया यार.
Can you please do it?
हाँ. क्या करूँ अभी, क्या करना है?
बोला था ना तुझे छोटा एक्सेस नहीं करने को. हो गया ना अभी कॉम्प्लिकेशन. अभी क्या करेंगे? रुक, मैं वॉश होके आती हूँ फिर देख. Okay.
So basically this can be still harsher. So you can actually use the local language, you can shout at the resident, shout at the junior, you can make the patient know exactly what has happened in the patient's own language. So basically if you don't teach them, how to actually behave in the OT etiquettes is something that we need to see. See, look at this. This is a very standard thing that happens.
Not that photo on the Facebook or Instagram, please. Not that. Please crop me if you're putting that photo and edit something, do something, put some beauty face, do something. Okay, I'll get back to you in some time and I'll send you one more photo which you can put. चश्मा निकाल ली? क्या हुआ?
Multitasking.
आंखों से पानी जा रहा है डॉक्टर को.
इधर आना एक बार. ये सब कब से हो रहा है?
10 दिन हो गए डॉक्टर.
हाँ, ठीक है. कुछ दवाइयाँ ले रहे क्या?
नहीं कुछ नहीं डॉक्टर.
Hello? Yeah, I've sent the photo which you should upload. Please upload that photo and all this one and tag me also. And do some nice editing work, please. 1 minute, I'll get back to you.
So she worked out what she saw on the slit lamp. So she wants to come
कब
back.
से सब शुरू हुआ बोल रहे हैं आप?
10 दिन हो गए डॉक्टर.
हाँ, ठीक है.
She doesn't know what to write because she has forgotten the clinical finding.
हाँ, ठीक है. हेलो. हाँ. How many likes did we get finally? हाँ, ये प्रिस्क्रिप्शन उधर लेके जाइए, वो एक्सटेंड करेंगे, ठीक है? हाँ, how many likes? We got some comments also. That's fun.
So basically, she would have probably done the right thing. She would have solely seen the clinical finding, given the right prescription. Maybe she has done her job correctly, but the patient is extremely dissatisfied. So this can be kind of a tool to show our postgraduates what not to do. So basically, like at the same time, they get to see sometimes patients with poor prognosis. No, how do you break the bad news?
मैडम बच्चा देखता ही नहीं है, मुझे पहचानता नहीं है, ना टाइम हुआ, किसी को उसको बुलाते हैं तो भी देखता नहीं है.
नॉर्मल डिलीवरी हुआ था बच्चे का?
डिलीवरी नॉर्मल हुआ था मैडम, लेकिन रोया नहीं था बच्चा डिलीवरी के बाद.
फिट्स आया था?
फिट्स 1-2 बार आया था, डॉक्टर को दिखाए थे हम, उन्होंने दवाई वगैरह चालू किया है, अभी तो ठीक है बच्चा.
तो बच्चा रोया नहीं, बच्चे को फिट्स आया था. अरे ऐसे में ये ब्रेन पूरा डैमेज हो जाता है बच्चे का. ये आंख का प्रॉब्लम नहीं है मैडम, ये देख नहीं रहा है लेकिन फिर भी आंख में प्रॉब्लम नहीं, पूरा ब्रेन ही. बच्चे का गर्दन भी नहीं बैठा होगा अभी तक, तो ये चलेगा भी नहीं, बच्चा बैठेगा भी नहीं आगे. हमारा काम नहीं है ये ब्रेन के डॉक्टर को.
So I'll just show one more last video.
डॉक्टर एक्चुअली क्या हुआ?
Your PGs can really
अच्छा दिख रहा था, अभी कुछ नहीं दिख रहा है. एक दिन से कुछ नहीं दिख रहा है, बहुत दर्द हो रहा है, बहुत दर्द हो रहा है.
The post-cataract sudden vision loss.
क्या हुआ डॉक्टर?
इन्फेक्शन हो गया आपको.
मुझे बहुत डर लग रहा है. इन्फेक्शन मतलब वही क्या? सेप्टिक?
हाँ वही जो हर बॉडी में हर जगह होता है. इन्फेक्शन वही आपको आंख को भी हो गया.
अभी क्या करना है डॉक्टर?
मुझे क्या कर सकते हैं? इन्फेक्शन तो हो गया. अरे वो बाद में सोचेंगे, अभी रुको, डॉक्टर आके देखेंगे आपको. इधर ही बैठिए.
So basically sensitizing our postgraduates to all such clinical scenarios. See, you can't expect them to learn the way how you need to communicate, handle these situations by themselves. So basically it's our duty as mentors to really show the right way. Okay, so maybe you need to show it, like you can probably show this video next to that.
मुझे 3 दिन पहले ऑपरेशन हुआ था डॉक्टर, इस आँख का. तब अच्छा दिख रहा था, सब कुछ दिख रहा था. अभी एक दिन से कुछ भी नहीं दिख रहा है डॉक्टर. मुझे बहुत दर्द हो रहा है.
टेंशन मत लीजिए, एक मिनट यहाँ पे रखिए. डरने की कोई बात नहीं है. आप करेक्ट टाइम पे आए हैं. थोड़ा सा रिएक्शन हुआ है बस.
करेक्ट टाइम पे आए हैं, टेंशन दर्द कम हो जाएगा, अभी ट्रीटमेंट देंगे, अभी बैठिए, अभी सीनियर डॉक्टर आके आपको देखेंगे, टेंशन मत लीजिए। पानी चाहिए आपको? कुछ
So all these things probably can help them rather than giving a PPT on the entire communication skills or ask them to read about it. So basically at the end, so it's your individual assessment. You need to assess every student because their level of vocabulary, their elocution, their communication skills, their personality types, and their entire, the language problem. There are a lot of institutions where they cannot really communicate in the local language because they are from different states. So you need to basically observe the seniors, the mentors, the teachers, have to sit behind them and see how they actually talk to the patients and create this kind of a dry run. And there are specific contexts, what I showed you, like we need to really teach them how to break the bad news, how to soften the blow. At the same time, O6 is a great tool. You need to really sit behind them and see what they actually do in real world situation and do it. So basically, as I say, it's all about communication. If you want to really create a period where you have a peaceful, practice, patients are happy, and you have a well-rounded up ophthalmologist for the future, we need to work them on the communication and professional training. Thank you so much.
Any comments on this? Or is slowly hypoglycemia creeping up? Perhaps. Yeah, you have a comment, yes.
I totally agree with KP sir. What most of the students we see nowadays is like the lack of communication. This communication is very important because it builds a trust. So I work in a government medical college where a lot of poor patients come. A little pleasantries like how are you, or talk to them 2 lines politely and they will trust you. And so the entire procedure like treatment becomes very easy. Like they don't doubt your whatever treatment you give, or they'll accept whatever the result of your treatment is. So communication is very important. And one more thing is this, though not all, most of this aggression by the patients and attenders is because of the inappropriate communication by the medical professional,
the junior
I feel.
Doctors.
Yes. So as soon as the patient enters, the way we talk to them, the way we interact with them, it will help to reduce all these assaults or whatever that aggression that occurs
So
on
we
the
are mentors, they are our
doctors.
tormentors. Yeah.
Yes.
All
No,
right.
I think it's whenever a patient says, I want to see the senior doctor, there is something wrong that has happened in the communication. Because sometimes a patient comes, he has been seen by probably a fellow, and patient asks for that fellow. He is not actually bothering about me, whether I'm there or not. That is a good sign that patient, because the seniority should show up. So obviously, all our students or fellows or residents have that in their mind. They don't behave like a consultant. They have been trained to behave like a postgraduate.
Yes, sir. So just a couple of things. First is language is a huge problem actually. We have many postgraduates from other parts of the country coming to Tamil Nadu. They have a lot of difficulty in communication. So it's not their fault, but we have to make that as a part of a curriculum to give them a training in the regional language. That's something what we do at Aravind. So we made a book called Essential Ophthalmic Tamil, got all the important Tamil words which are relevant for them to speak to the patients, and we made like audio video out of that. That's one thing. Second is that when I applied for UK, we have to pass an English proficiency test, something called as IELTS, which is very difficult to pass because it can be very generic in the way they ask the questions. Like, how was your day? That will be or you see a crying child on the road, what is your response? That will be the skills. But there is another thing called as OET, Occupational English Test, which is what I took, which is very easy because they're creating a healthcare simulation where the speaking skills will be, there'll be a patient and you will be the doctor. So the interaction is much easier. The way they grade the OETs, they have a checklist, how to score those, the candidates who apply for that. I saw that was so useful. Then I got all the flashcards and the assessment system. Then we are currently using in Aravind to train our postgraduates and our nurses on how to talk. This will be a great model. I would strongly recommend you to go and see the Occupational English Test, speaking models and how they assess that speaking skills.
Thank you, Pranish. Thank you, Dr. KP. We're going to conclude this session with an actual problem resident. Yes. No, not Rolika, not the problem resident. She's going to be speaking about a problem resident's scenario number 1. And then we break for lunch.
Yeah, I'll take mine.
While she's setting up, I think one common problem that we've noticed across residents from undergrad, postgrad, fellowship, and it continues even in our practice, is the practice amongst us, and all of us are guilty of dehumanizing patients and referring to them as patients. And even while we are showing a colleague, we'll say, yeah, this patient is here, this, I mean, it's as simple as a case, yeah, that case. And you call him that syphilis case, that sarcoid case. And yeah, exactly. So, and we don't even realize we are being wrong. And things like, dispose of these patients, check out these patients, or whatever we use. So that's something that we have to consciously make an attempt not to do, especially when we talk about.
They don't greet the patient. They don't ask, good morning, how are you, whatever.
Language was spoken of, but I think non-verbal communication is hugely important. Even if you are not able to communicate in the language, your empathy shows your attitude, how you meet and greet a patient, and so on and so forth. So I think that is a very important part, not just your showing it, but also looking at the cues from the patient of his non-verbal communication. These are very important in clinical practice.
I would like to be a little bit disruptive in terms of the communication. I don't know if this is something that resonates with you, but at least in Portugal it exists, and I think across Europe, but in my country and where I work, it exists. It's the definition of patient and the definition of client. And we can see that, for instance, if not all, at least several private groups of healthcare providers use this designation towards the patients, so they are the clients. And when we speak about clients, and this is something that I would like to know your approach to this, because when I went to medical school, to the Faculty of Medicine, I thought that I would be providing services for patients. I would be not a provider of services, but someone who would be there to help others who would benefit from my help. So for at least these last few 10 years, but last 5 years, this definition has been taking further strength in terms of defining the people who come to me for my services. So I see myself as a service provider for a client. And how this can affect our communication, knowing that on the other hand, for instance, we can see models in the business world that also employ empathy for providing the best service for their clients. So this is something that I would like, might be a little bit disruptive, but in terms of communication, this is something that we also have to prepare the residents to be equipped to do. Probably they don't feel so much this because they are contemporary with this kind of approach and don't have so much the experience of the past. But anyway, I would like to know if you...
This is a huge issue, how the patient-doctor relationship has evolved. In India, in specific context, the Consumer Protection Act came in. And once it did, it altered the relationship of trust to a relationship of a provider and a receiver. And that has been a huge impact. I mean, over 45 years of whatever I've seen of practice of patients or ophthalmology, there's a huge change in the kind of trust and relationship and the kind of attitude that the provider or the physician at that time had towards the patient, of thinking of everything in terms of what is medically right and behaviorally right for the patient, to now a fairly much more protective mindset about making sure of looking at your back to make sure that nothing is happening. So there is a huge sea change in those 45 years of my practice.
Yes. So before I begin, I just want to confirm how many mics do we have and where are they spread out? We have 2. Okay. Because this is going to be absolutely interactive, and this is where I need the comments from all of you. Yeah, perfect. All right. So this is, okay, not this slide, my slide. Okay. All right. So problem trainees, and the interesting part is that the room is full of trainers per se, so it will be great to know your perspectives and it will be useful for everybody in general. And I thank the Ophthalmology Foundation for considering me for this talk, and I think I'm the baby ophthalmologist in the room, so I'll be happy to take it that way. And disclaimer, all problems stated here are highly fictional and they're absolutely not related to anybody. And no humans were harmed while creating these scenarios. You may or may not correlate with the scenario. Good for you. So this is the concept which a fellowship is built on. See one, do one, and lead one. And how I like to put it across is that your fellowship is kind of divided into 3 categories. The first year, or maybe they say the first third of your fellowship, is when you are seeing one. That means you're observing. So everything that you do is about observation. Observing your seniors, observing your mentor, and observing the entire system and building on it, right? Next is do one. This is the middle third of your fellowship where you're actually, put in the taskbar where you have to perform and you have to make sure that you're doing it right based on whatever you have seen before. And the third part is the lead one part, where now you kind of have to lead the rest of the crowd. So these are the 3 parts of the fellowship, and I will be taking 3 scenarios from the 3 different parts of a fellowship. So the first is C1. So observation is the key in training. Observe the seniors, that's the key. And all of you who have been here who have done their fellowship or their training and now are making sure that their fellows are trained, you will agree with this part. And I know that many of you would highlight and say, please observe whatever is going on. Don't try to just fall into the system. Don't try to participate early in the system, because here we are dealing with patients. We are dealing with real situations, and it cannot be just hit and trial. But does everyone want you to observe? That's the interesting part. Because when you're doing a fellowship, everybody around you is looking at you as competition. So how do you combat a competition? Okay, so that's a part. So while you are in the phase 1, that means that you're seeing and you're observing. At the same time, there's somebody or the other who doesn't want you to observe anything. And that's the part where I would like to say, this is the phase where you realize that it's the realizing the real lies. That means that you have to make sure that you're the best judge of what to observe, what to learn, and what to ignore. But let's go to the case scenario. So this is the case scenario from the phase 1 of the fellowship, and that is, you're just a newbie in the, say, 3rd month of your training, and you were asked by your mentor to learn a particular technique. But your senior colleague tells you to ignore such a command, as it is not yet the right time for you to be learning that technique. What would you do? Now, since the room is full of trainers, I would like you to highlight the part which you would expect from your fellows to be doing. So this is over to you all. So we have 2 mics here, and would anybody want to step up and start the conversation? Or I'll be happy to pick. Yes, Dr. Prashant.
No, I think there is a problem with the senior colleague who is saying that means there is a poor relationship between the mentor and the senior colleague itself.
Okay.
As a mentor, what I will like is that if truly I have mentored my fellow well, that fellow should imbibe the same ethos and culture that I have in my work.
That's a very good point.
If I want my youngest mentee to do or observe something, my senior mentee should support that approach.
Agreed. And I think one should keep that in mind, that when you are in a fellowship, it's your responsibility to make sure that the system goes on the same way like your mentor has designed. That agreeable. Anybody else who would like to add a comment? Dr. Helena?
Well, I was thinking on the side of the fellow, it probably, if the fellow was very keen and very focused on learning that technique, would the fellow need to learn that technique from that particular senior colleague?
There is only one.
Well, that is very, well, and probably the fellow should have to report to the mentor what was going on, right?
Right.
Well, probably that would be the key. I mean, it's not something that you would be crying out on the shoulder of the mentor, but at least reporting what was happening, probably, and that would solve, as Dr. Prashant said, probably.
Right.
Well, this doesn't mean that some feeling of some comfort could, because seemingly they were not in the same page, which
Right.
is not very nice for the fellow.
I agree with you. In fact, I would just like to add one point, and that is that this is a scenario which kind of happens with most of us these days. And I do agree that this was not the phase when probably when you all were getting trained, because that was more cordial scenario. But nowadays, like for example, in this situation, the trainee is stuck because the trainee cannot go to the mentor and ask for that training, because that's not their zone, that's not their responsibility. And at the same time, there's no other way to learn but from the senior colleague. And that's why I put the word as senior colleague in the same, in the same phrase. Because technically that person is just a few months or, a year ahead of you, but still is a senior. So there is an authoritarian component that comes from the senior colleague, but at the same time you have to learn from them.
I think this whole scenario should be looked from the perspective of the learning center, or the center who is providing fellowship has serious flaws here. Because if I am a mentor, I have the responsibility to run the show. And I have to ensure that junior or senior, all of them are learning to the best of or in the best interest.
Right.
So if the system is that the learning of the junior mentee is dependent on the senior mentee, that means mentor is irrelevant in that system.
Correct.
So that's where the organizational problem starts.
Right.
You are not a right kind of a learning organization.
Agreed. And also, I do believe that when the education gets rolled over from a senior colleague to a junior, it breaks, because it's like Chinese whispers. So what has been taught originally, by the time it gets passed on for 5 generations, it's gone, it's faded, and it's probably something else. So the training has to come from the person who is in charge, and that's the mentor.
I think we are quite presumptuous. Maybe this is the right situation. Probably the mentor may not know much about the mentee, the junior mentee.
Correct.
He says you can just try a topical phaco in the next OR, but your senior colleague has seen you enough. He thinks your microsurgical skills are extremely, deficit. There's a lot of deficit. He says it's not time for you to do topical. Maybe he is cautious enough to probably warn you that don't be, So this may be actually seen in the right perspective also. So it all depends upon the situation and the kind of the person the mentee actually is going through.
Yeah. KPC always likes to see the optimistic part of it.
And probably building on that idea, asking the senior colleague, okay, what should I do to start in that pathway? What should I do first?
Correct.
Or what techniques should I learn before that can lead me to learn this specific that my mentor has advised me to do right now? So probably trying to build this relationship with the senior colleague?
Well, the answer that how we see it is that it's easier to be diplomatic than to be competitive. And in this approach, it's actually good to go to the senior colleague and put it across that, hey, you do the particular technique till you're supposed to. I'm not interfering. I'm here to learn. Teach me the system. I'm not going to do it till you're gone, but at least it should be passed on to me the way it's supposed to be. So your competition is taken care of, your a gap is taken care of, and you're absolutely able to learn. So that's one way of saying it. And then we come to the next part, and that is the do one. So what's the case scenario from do one? This is the second phase of the fellowship, and which says application of what you have learned so far. And it's a premature application, of course, but your patients need you to be confident, and so does your mentor. And that's what Dr. KP just spoke about how the communication skill and the patient communication interaction. And are you doing it right? Always questioning yourself. In the fellowship, you're absolutely in touch with the patients. You are out there, you're interacting with real humans, right? It's not like a simulation over there. And are you doing it right? It's performance time in front of your mentor. Everyone around you is always judging you. And it's a part which many of us go through because it's a part of training. At the same time, it's practice. So the case scenario from this phase is that you're now in your second year of training. You're asked by your mentor to operate on a case yourself under the supervision of your senior. You now are being you are being watched, and your hand is being held by someone who is a few months ahead of you in training. And everyone is watching you while you're operating. What do you do? So this is a part where, again, the trainers have to put in a suggestion on how the trainee's approach should be in this particular problem.
I would say that, for the part of the surgery, most probably the patient knows that there are trainees, and this is they are being taken care in a teaching hospital or clinic, so they know about that, and most of the consent forms signed have that expression also there. But what I think it is, and it's building the trust, as we have been seen before, is communicating with the patient, saying, starting by introducing yourself, saying that you are a fellow, you are someone who is learning, and then from there, usually the patients enjoy that. The patients, because it's something that is towards their side, and they deposit usually they deposit very trust in those who are learning, because they study, they are very interested, they have someone to tell their stories about, that usually have more time available to hear their stories. So I think this is something that can be an icebreaker, that can be completely alter the whole relationship and communication afterwards. And for the trainee, is something that also builds self-confidence. For the surgery, it's a lot of, brain training, Zen feeling, but I can understand what the story presents there. But you have to take a step back and watch what you're saying, what you have learned, what you have progressed so far, and that you are in training still, and you have the best around you to help you, and that is the kind of feeling and mindset the person has to develop at that stage. I would say this.
I think it's all about developing the confidence in this phase.
Yes, sir.
So Ralika, I'll touch upon the other aspect of it. Once your mentor has observed you over a period of time, He has seen your abilities. You have observed for a significant period of time. You have assisted for a significant period of time. It is his confidence that is reflecting in the decision to ask you to operate as an independent surgeon with an assistance by somebody senior. So it is, the other aspect is of how much confidence you have imbibed. So you have to, over a period of time, have built up a certain confidence by being in that environment, by observing, by assisting. So you have to bring that confidence into play to feel good about that you've been asked. That means it shows the confidence of the trust of the senior in you, and you should be able to repay that trust by your inner confidence. And it is a step in building up your confidence in doing it independently.
Right.
For reasons of time, we'll have to wrap up,
Yes.
Dr. Rolika.
Sure. So I'll just quickly go to the last case scenario, and that would be a really short one. So the lead one part, there is no textbook answer on how to lead. A lot comes from trial and error and by discussions with the experts. And expectations are higher at this stage. Responsibilities are max at this stage, and it's all about what you have learned so far and even more. So the case scenario from this session, and that would be the final one, would be you're now in the final phase of your training and you're asked by your mentor to train your junior colleagues who are probably the same age or even older than you. They refuse to listen to you the same way because they don't see you at the same level as your mentor, of course. But the scenario doesn't change. You're responsible, and you're supposed to train, and you're supposed to lead. Your mentor's wish is your command. What would you do?
Since I have the mic, I'll start. There are two things. One is that the relationship that you have with a trainee or with a junior is all dependent on how good you have been to him in not having that competitiveness which you spoke about. I think one has to realize that teaching is the best teacher to yourself. You best organize your thoughts, you learn everything by teaching. So there is no sense of competition really. If you have any traits of a teacher, you don't ever think of competition. So in that sense, if you are a good teacher, you would not have that sense of competitiveness. You would have taught your juniors, and once they see that reflected in your attitude, you never find this kind of attitude. It's virtually rare for someone junior to be kind of arrogant with you if they feel you're genuinely good to them and genuinely helping and teaching them.
Right.
So it's a mutual relationship which you build over a period of time.
Whether they pay respect or not, it's up to the teacher. Like, we make them interest in the subject and teach them in material, whether they are giving enough respect or not.
Right.
Yes, that is the best way.
Thank you, Dr. Rolika. Very interesting scenarios from an educator who is in training perspective. Thank you.
Thank you.
So we conclude this session, and the next session starts in 7 minutes, so that's time for lunch. No, I'm just kidding. Please try to be back by 2:30. I'll quickly I'll request to distribute the certificates. Dr. Helena, please distribute the certificates. Dr. Grover. Thank you. Dr. Akshay Nair. Dr. Krishna Prasad. Yeah, as a speaker. And Dr. Rolika Bansal. So I'm just going to say 2:35. So there's plenty of time. Correct?